Welcome. You could have the recording from last year. It might be about the same. Okay. Now we can't say anything bad. So the way obesity is really classified and body habitus is classified is the body mass index. It's really the most commonly used one, but it's probably the least accurate. It was really designed by insurance companies as a way of stratifying their clients. But with that being said, it is the most widely used tool that we use to classify body habitus. You need to know this formula. You'll see it time and again, both on boards as well as some places you still have to calculate your BMI for EMRs. Most of the newer ones like Epic and Cerner go ahead and calculate it for you. But there are some problems with BMI. The biggest one being that it's literally just height and weight. It doesn't account for any sort of body habitus at all. Uh, so somebody that's 200 pounds of solid muscle is the same as 200 pounds of solid fat. When you look at some of the more accurate systems, you'll see that they usually account for waist circumference, waist to neck ratio, waist to hip ratio, and then there's usually an age component as well. But it just kind of depends. But BMI is the most commonly used one and the one you're probably going to see time and again. There's two common distributions of fat. You have android, which is kind of central obesity, so like the upper body, usually like truncal obesity. These are the patients that we generally have to worry about an increase in oxygen consumption, an increase in cardiovascular disease. Most of the side effects here come into play with the android obesity. Gynecoid obesity is generally a little bit more of the periphery, so hips, butts, thighs. Oftentimes, you can kind of pick these people out by their calf size, their forearms. They tend to be a lot less active, and especially from a metabolic standpoint, you see there's kind of a big difference there. But the interesting thing is, even though they're less active, they generally don't have an increased incidence of cardiovascular disease. So you'll probably see that again. From a cardiovascular standpoint, things you have to worry about with obese patients, generally the total blood volume is increased because of the increase in literally like miles of pipe that the blood has to flow through. Most of that's going to be distributed throughout the adipose tissue. As a result, their cardiac output's generally a little bit increased, but you also tend to see that there's a little bit of increase in their left ventricular dilation, and as a result, their stroke volume, just to perfuse that increased tissue. You do also see an increased incidence of cardiac dysrhythmias, which really isn't a surprise, primarily due to CAD and some fatty infiltrates throughout their cardiovascular conduction system. You may also see when you look at their EKG that just because of the distance between the monitoring site and the heart, that there's a kind of a decrease in the QRS voltage or amplitude. And then you may also notice the left axis deviation and then the LVH as well. From a hematologic standpoint, generally you see a higher level of clotting factors, which is problematic just because they have so much more vasculature. They tend to have an increased incidence of clotting disorders. So things like DVTs, PEs are a little bit more predominant. And then you couple that with their decreased activity level. It's kind of a setup. The interesting thing is because of their decreased activity level, they tend to be less symptomatic than patients that are more active and have a large PE. So the other thing is they tend to have like a serial of events. It's not just like a one-time PE. A lot of times you'll see that if they mobilize or experience some sort of life change, that they'll start showering little microclots. So as a result of that, they kind of build up a accessory pathway that lets them get through the event a little bit easier. Also tend to have a little bit of an increased incidence of endothelial dysfunction, just because the levels of factor VIII and von Willebrand's being a little bit higher. System is kind of an interesting perspective in these patients, especially because for so long we were fixated on, simple math, what was going in versus what was coming out in their activity level, and that how it impacted their body habitus. But other things that we have to kind of take into consideration, especially now that we're looking at like gastric ultrasound and those sorts of things, and like GLP-1 agents. Um, when you look at the stomach, you'll see that the gastric volume and the acidity are a little bit increased. They also have delayed gastric emptying. Um, it's kind of a perfect setup when you've got somebody that's already at high risk for pulmonary issue, And then you've got an increased gastric volume greater than 25 mLs, and then a decreased pH less than 2.5, for them to vomit, aspirate, and wind up with an aspiration pneumonitis. Because of the body habitus, you also tend to see that there's an increase in the intragastric pressure. And as a result of that, that lower esophageal sphincter will relax a little bit, and they tend to form hiatal hernias. Oftentimes, these are asymptomatic and really just get detected while they're looking for something else. You will also see that when patients go in for like sleeve gastrectomies or lap bands, that commonly they will have a hiatal hernia repair as well. Renal standpoint, your renal blood flow is increased, as is pretty much all the other blood flow. That's not really a surprise. And then they have a little bit of increased renal tubular absorption, which tends to activate the renin-angiotensin system. As a result, a lot of times they'll have a little bit more increase in blood pressure. So it's kind of a constant battle for these folks, regulating the miles of vasculature, regulating their fluid status, and then kind of pairing that with the decrease in activity. The endocrine system is really one of the big things we're kind of starting to understand for these patients, especially when we start looking back through a lot of their history and kind of how they wind up in the situation. Outside the role of genetics, we're starting to figure out that there's a certain percentage of the population that's predisposed to diabetes. And we don't entirely understand why yet, but we're slowly starting to figure it out. But, you know, a lot of times we just kind of chalk that up to being genetics. But what we do see is these people tend to have kind of a sympathetic overdrive. As a result of that, they tend to have impaired glucose metabolism. They're resistant to insulin. They tend to have higher blood pressures, so they've got increased activity of norepinephrine and angiotensin 2. They tend to retain sodium, which coupled with the poor diet obviously contributes to their hypertension as well. And then they also tend to have thyroid problems. Other things, a lot of times you'll see kind of fall in this pathway, diabetes, a lot of the other autonomic disorders, POTS, chronic pain syndromes, those sorts of things tend to go hand in hand with a lot of these same patients. So continuing on to that, the other commonly associated diseases, as I mentioned, diabetes. OSA, I really consider to be more of a side effect of the underlying process in most patients, but you will find patients with essentially like 5% body fat that still have OSA. They tend to have asthma, COPD. Again, a lot of these things tend to be interconnected. You know, were they smoking, which led to the COPD, asthma, and then that contributed to their poor cardiovascular status and their diabetes, or, you know, kind of which came first. Ultimately, you also tend to see an increased incidence of cancer in these patients, as well as osteoarthritis. The osteoarthritis is generally associated with just the increased wear and tear on their joints as a result of the high body habitus. So metabolic syndrome is kind of the cluster of what we used to use to define diabetes and the symptoms that go along with it. It's really more of a progression than just kind of one point in time. But first thing you see with these folks is they generally have a little bit of abdominal obesity. Their HDL levels tends to be decreased. They have elevated triglycerides. As a result of that, you can kind of start guessing that perhaps the diet isn't the best. Tend to be resistant to insulin, intolerant of glucose, and then as a result of this continued progression, they become hypertensive. And as we were talking about before, they tend to have kind of a pro-inflammatory and a pro-thrombotic state, so prone to clots, prone to systemic inflammation. To meet the definition of metabolic syndrome, they've got to have at least three of those. The most commonly ones we see are the triglyceride problems, the obesity, and then some sort of hypertension. Um, One of the things that we commonly look at in these patients, as opposed to using BMI, is looking at their actual waist circumference, because it tends to be a little bit more accurate for these patients, and it's not an insurance company trying to figure out how to cut you out of benefits. Other things we see is that they tend to be at an increased age. There are increasing numbers of young patients with metabolic syndrome or pre-metabolic syndrome. It generally affects men more than women, and minorities tend to suffer a little bit more than Caucasians, especially Hispanics and South Asians. The other thing you'll see is sometimes this is independent of genetic factors. It may be as a result of medications. Steroids are one of the biggest ones we think about. but you'll also see that antidepressants and antipsychotics may contribute to it, um, although they may be on those medications for an underlying disorder that it was trying to treat as well. Patients with metabolic syndrome are, if they don't already have it, already at increased risk of CV disease, diabetes. And then we start getting into a lot of those kind of autonomic things I was talking about, POTS, polycystic ovarian syndrome, non-alcoholic fatty liver disease, and then they tend to have like weird immune responses. I think one of the interesting things that came out of COVID was we really had a kind of a focused group to look at people with a lot of these autonomic issues. So we were able to kind of figure out, treatments for them as well as look at those syndromes a little bit more in depth. So I think that was kind of interesting to kind of have that perspective on things. The good news is usually these people with treatment will do a little bit better. A lot of the times, or at least in the past, the go-to was bariatric surgery. Um, since then, and we're going to talk about GLPs in a minute, but the go-to is GLP-1 inhibitors. And what you see is when these patients lose the weight, a lot of times they resolve almost all these issues. So like diabetics coming off insulin, people's blood pressure being corrected, whatnot. We talked about OSA the other day a little bit. We're going to talk about it some more. You've got two different kind of similar situations here. You have obstructive sleep apnea, and then you have hypopnea syndrome. A lot of times they get coupled together, but they're not necessarily the same thing. So with obstructive sleep apnea, you're actually having periods of apnea. With hypopnea, it's really just a decrease in airflow. So for OSA, it usually lasts about 10 seconds or more, and you're having 5 or more events for each hour of sleep. If you do continuous oxygen monitoring on those patients, they will desaturate during that time. But usually it requires kind of long-term testing to figure out where they're at. Hypopnea, similar incidents, except it tends to happen a little bit more, same kind of duration, same decrease in SpO2, but they're having an actual airflow reduction. So as far as like testing, a lot of times these patients will not only have kind of monitoring for oxygen saturation, but they'll also do spirometry while they're testing them. So the sleep study I was referencing is also known as polysomnography, and literally they're just looking to see how many events they have during a certain period, usually an hour. Sometimes they'll trend it for longer periods of time depending on the patient. And treatment really is based off of two things. One, correcting the symptoms, and then two, correcting the underlying cause. So, as I said earlier, if it's related to body habitus, a lot of times they'll just focus on weight loss. So, perhaps exercise, perhaps changing kind of nightly regimens. If these are people that are using any sort of sedatives or sleep medications, a lot of times they'll try and eliminate those. But if they're not able to correct it pretty quickly, you'll start to see if they don't already have it that they'll develop systemic as well as pulmonary hypertension, LVH. They tend to have dysrhythmias. And then this is one of the ones we're really just kind of starting to understand the effect of the cognitive impairment. And I guess it makes sense, if you're not getting enough sleep, that you start to have some sort of intellectual dysfunction. So just something to think about there. Losing sleep can be more than just being tired. Kind of the continuation of this is what we call obesity hypoventilation syndrome. It used to be known as Pickwickian syndrome, and I guess that wasn't nice, and people didn't like having a term. So we started calling it OHS instead. These are patients that have long-term obstructive sleep apnea. So it's really a low percentage of the overall patients. And this is when you start to see a lot of pulmonary complications, primarily pulmonary hypertension and cor pulmonale. When you see these patients, so there's little doubt that that's what's going on. These are the people that even though they're wide awake, become hypercapnic. The quote, the official definition is a BMI more than 30, but usually these folks have BMIs of 50, 60, even more. If you think about, I think it's like my 500-pound life or my 1,000-pound life or whatever, these are those patients we're talking about. So we're going to go back in time a little bit to what used to kind of be the cornerstones of medical therapy for these folks. We started off using phentermine, um, which was basically just an appetite suppressant, and you were really only supposed to use it for short periods of time. Unfortunately, most of the patients weren't able to kind of retrain themselves during that 3-month period, so we started seeing people using it for a lot longer periods of time. As a result of that, they started to develop cardiovascular symptoms. The biggest one was palpitations. Obviously, they started losing weight, so they became dependent on it. But like I said, if they weren't able to retrain, then they tried to continue it outside that window. Originally, it was manufactured as a combo medication with fenfluramine, so you may have heard of fen-phen. But especially with the longer use, we started to notice that there were valvular defects occurring, increased incidence of sudden death. So, not good things in a patient that was already kind of high risk. The next class of medications we used was orlistat, which is still available. It's available over the counter for that matter. And what it would do is basically just block the absorption of dietary fat. As a result of that, the patients would kind of have like large liquidy stools. Um, I think, from my understanding, it was really uncomfortable to take. They would have like profound abdominal cramps. They did start to develop some malnourishment because of deficiencies in long-term use. And then the other thing you saw was that you started to have some clotting disorders, so their vitamin K levels would drop off. Uh, I think one of the interesting things was like just talking to people that had taken this was this they couldn't like go anywhere. They weren't able to go more than like 5 feet from a bathroom without feeling comfortable. So I think that's why a lot of people kind of stopped that. There are some over-the-counter ones out there. If you think back, I don't know when ephedra went away. It's probably like 20 years ago, 15, 20 years ago. There were a lot of weight loss products out there, as well as like a lot of dietary supplements that people were using to increase their heart rate. It was basically because the active ingredient was ephedrine. So it would work. The big ones had either ephedra or like mawang or some of those things in it, depending on what was like banned at the moment. It worked really well. People got their heart rate up. They sweated more. They lost weight. Unfortunately, they also kept dropping dead. So not good when young people are dropping dead because of their workout supplements. So it was pulled off the market pretty quickly. In So I think all the other ones are pretty much still out there. I don't know how much clinical research actually supports their use, but anyways, uh, looking at your questions, thanks for correcting me. I couldn't remember what it was, 500 pounds, 600 pound, whatever. That guy's actually in Houston. If you know anybody down at, it used to be St. Joe's in Houston. That's where he films most of his shows at. So then enter GLP-1s. In a lot of these things, it's kind of interesting how we figure out medications, work well for one thing and not another, because this concept isn't really new. The GLP-1s are a new class of medication, but we had people that were taking metformin before. We had people that were taking insulin before just for weight loss. I think the biggest thing is that the GLP-1s don't have a lot of the side effects that metformin and especially insulin had. So that's probably why they're a little bit more popular. These are couple of the different medications that are out there, and you'll see that they come under multiple different brand names. And then the other thing you see is that a lot of times these medications aren't even going through their brand name anymore or their trade name, that they're being compounded just for cost savings and availability. So you've got to be really cautious as far as what medications patients are taking because they may not be going by the same name. It may be a little bit harder to recognize. But essentially, the way these medications work is that they slow your gastric emptying so you stay fuller longer. There are some other things depending on the medication itself, but they all basically work by delaying your gastric emptying. The amazing thing is how well they've worked. You're talking about people that have lost, 50, 100 pounds. I don't remember the exact percentages, and it does vary by medication. But as I recall, like the FDA approval was like low end 10% and high was like 15%. But obviously, you have outlying case studies that lose even more than that. The concerning thing for us is the anesthesia implications of these medications. So anytime you have somebody with a delayed gastric emptying, they're at increased risk of aspiration. So the big question, and I'm going to pop back a slide, is how long do we hold these medications? Um, it depends on the medication, how long you really need to hold it. Some recommendations are a couple days, some are a week, some are 2 to 3 weeks. I've personally seen patients going in for endoscopy that are on GLP-1s that have retained gastric contents 2 to 3 weeks after their medications. Good news is you're already there with the scope, so it's easy to decontaminate. But if you imagine just going in for a routine procedure and next thing you know, you figure out they've got a full stomach, it can be problematic for you. So obviously we want to hold it on the day of the procedure. But I think the current recommendation I read was 2 weeks. But we're really not sure because every time we come up with a number, there's somebody that kind of proves it wrong. And we'll talk a little bit about kind of mitigation strategies in a second. The other thing is you got to remember what these medications were originally intended for. If you have somebody that's taking GLP-1 agonist for diabetes, we want to consider holding it a little bit longer. But the other thing is we've got to remember that they're going to need something to manage their glycemic changes during that time period. So a lot of times it's not just a procedural thing. You may need to involve the endocrinologist as well to kind of figure out what we can do to cover them during that time period. So what do we do on the day of the procedure? Obviously, if they show up and they're nauseated, vomiting, we probably want to go ahead and cancel if it's elective. If it's not, then we'll consider them a full stomach and go ahead and proceed with an RSI. But there is still increased risk of regurg and aspiration of gastric contents. So kind of the full court press, think about things like Pepsid. Sidra may be an option for them as well. So you guys have had great exposure to gastric ultrasound, and I think the utility of gastric ultrasound has really been heightened with GLP-1 medications. The question is really how do we apply it? We've got these patients that we're doing gastric ultrasounds on because they're high risk for aspiration, whether it's because they're taking GLP-1s or something else is going on. I think you always have to maintain kind of a high index of suspicion for these patients, even if you have a negative gastric ultrasound. If you're ever in doubt, do the safest thing. Either consider canceling the case or treat them as a full stomach and perform an RSI. There are some places that they recommend putting in a gastric tube beforehand. The problem you run into with the gastric tubes ahead of time is you're kind of creating a portal for things to come out through the lower esophageal sphincter. So they're at increased risk of aspiration, and you may have been the one that just created the conduit for that to happen. But I think this is definitely a valuable tool, especially for patients that you're otherwise considering low risk. I don't think a kind of negative gastric ultrasound is really that assuring for me. So most of the time, if I was already in doubt, even with the gastric scan, I'm probably going to go ahead and consider them high risk. So from a pre-op standpoint for these patients, what do we look at? The big thing is looking at their underlying disease processes, figuring out how well controlled they are. Is there something we can do to kind of maximize their conditions? So look at things like hypertension, what is their blood pressure, diabetes, how well is their sugar controlled, and then we start worrying kind of about the more insidious things like heart failure, hypoventilation syndrome, and how well those are managed. That's where a lot of our problems come from in these patients long term. So if you're thinking about somebody that's obese already and you're not sure, you probably want to consider getting an echo, especially if there's any sort of indication of functional limitations. Likewise, if you're not sure how well they're breathing, they look like they're a little suspect, I would certainly consider getting spirometry. Probably not to the point of getting like FEVs or anything like that, detailed pulmonary function test, but just see what sort of volumes they can get. And a lot of times you can sit at the bedside with just an incentive spirometer, seeing how well they breathe. Other things to think about, if you have these folks, a lot of times they do have obstructive sleep apnea. If they're on CPAP and they've got a CPAP pressure greater than 10, anticipate that they're probably prone to obstructing, obviously, but that they may be very difficult to mask ventilate. So that may be somebody you want to consider having them very awake for induction as well as for emergence. Sometimes these patients, you'll see, you really just kind of have to manage them almost like a difficult airway, even if you think it'll be okay, just because they are at an increased risk. Other things to think about, their surgical history, because as I mentioned, especially with the kind of bariatric surgery that a lot of these patients are had in the past, they may not be in kind of the same body habitus that they used to be. You'll see that this is somebody that used to have weighed several hundred pounds and now they're a lot smaller than that, but they may still have some of the ill effects they did before. So just be cautious, kind of hallmarks when you start looking at these folks. stretch marks, loose skin. Looking back through their chart, and you notice that 2 or 3 years prior that they were a lot larger. Just think about things like that because it may have resolved all their symptoms or it may not. So just be cautious with those patients. Other things to think about if you're able to pull previous anesthesia records, how difficult were they to intubate in the past? You may see that even though they were really large or are really large, that they're not necessarily difficult intubation, but they certainly give us pause when we see that. So if you have previous airway notes, it's kind of helpful for you. IV access can be a struggle in these patients. Uh, Fortunately, now we can use the ultrasound for vascular access because it's not so much that they have bad veins, they're just covered by a lot of overlying tissue. So if you have the ability to use the ultrasound to see through there, it can kind of help you out. Other things that come into play, is this somebody that's going to need to go to the unit afterwards because of these underlying complications? As a result of that, you may consider pushing them either to a hospital or to more of a tertiary care center. So probably not somebody you want to do in a surgery center, probably somebody you don't want to do in a critical access hospital. So just think about things like that. From a surgery standpoint, they may be okay, but sometimes the surgeons don't think about the anesthesia side of things. And then the other thing is they tend to do poorly with surgery. They have poor wound healing. They tend to get infected. They get PEs. They're not out of bed very quickly. So you need to kind of evaluate, is this really what should be done for this patient? Just like when we were talking about pain stuff the other day, a lot of times these patients will be forced into losing weight before surgeons will operate on them. So whether it's a total joint or just a hernia repair, they may need to lose weight before the surgery itself. Other things to think about, these patients generally have kind of complex medical history, so many times they're on multiple different home medications. So what are we going to continue? What are we not going to continue? You don't want to disrupt everything if you can help it for a short surgical case. So a lot of times what we'll do is continue everything up to the day of surgery, but there may be exceptions to that. If you have somebody that's on ACEs, a lot of times we'll go and hold those for a couple days beforehand. If that's just somebody that's on an oral hypoglycemic agent, you may have to transition them to insulin for a little bit better control. Or you may just kind of loosen your controls that day as far as their glycemic status. Um, Sometimes it's okay, sometimes it's not. It really depends on the patient and how significant their disease is. Almost all these cases are going to get antibiotics just as everybody else would. The one thing to think about is that oftentimes these patients will require a higher dose of Ancef. So depending on your facility, if you get over 100 kilos or over 120 kilos, lots of places will increase the dosage to 3 grams. Certainly should be on DVT prophylaxis as they are high risk. From an equipment standpoint, though, you may have problems because things like SCDs may not fit. We see the same stuff with like blood pressure cuffs and things like that, that they may be applied in kind of an abnormal fashion. How does that affect your measurements? And then certainly some sort of aspiration prophylaxis for these patients, whether it's something like Pepcid or a little bit more intense. From an airway standpoint, we tend to see that they have lots of pulmonary abnormalities, decreased vital capacity, inspiratory capacity, ERV, FRC. Their compliance tends to be very poor. And the other thing you see is that a lot of times, depending on their position, their closing capacity may be almost the same as their tidal volume. So especially if you take these patients and lay them down or put them in like a semi-recumbent position, they may do poorly. From an anesthesia standpoint, we kind of have to figure out what we can do to counter that. So we may intubate them sitting up and we may extubate them sitting up. They tend to desaturate very quickly. So just be mindful of that. These are the patients you want to make sure they're awake and fully participating in their care. So consider using Sagamodex as a reversal agent for all these patients. So in the OR, some things are pretty similar to other patients, but this first one here, positioning can be really difficult, and we're going to talk about that in just a second. But other things you may struggle with, airway management. A lot of times we're aware that they may be difficult, so we kind of plan for the worst. So think about alternative airways being available, having a fiber optic scope in the room, having a glide scope in the room. It doesn't necessarily mean you have to use it, but you need to have it available for you. Um, because you never know when these things are going to go poorly. Other things to think about, just because their body habitus and disease processes, you may consider putting in an arterial line for these patients for a case that you wouldn't normally do it. It may be something like putting in an arterial line for an ERCP. But you'll also see that you tend to have a hard time not only regulating their hemodynamics, but also just obtaining it. The blood pressure cuff moves around. You're not sure it's accurate, things like that. Choice of anesthetic technique, we'll talk about that a little bit more in a minute, but just be very cautious with these patients. They tend to wake up very slowly no matter what your anesthetic technique is. So if you're able to do this under regional or interaxial, that may be a better option for you. Other things to think about as far as like agent selection, something that doesn't stick around quite as long. So, for instance, think about doing a neuro case and you're doing a TIVA. Propofol may not be your best friend here, just because there's so much opportunity for it to kind of stay out in the tissues for a long time. So you may consider using a reduced dose of propofol and adding something like ketamine, or remifentanil is a nice one here because it tends to not stick around nearly as long as the propofol would. From a pain management standpoint, it's a very hard balance because you don't want them to hurt, but you also don't want them so sedated that they don't breathe. And then fluids can be very difficult just because they do have kind of an increased fluid need. So just be cautious. So depending on the patient's positioning, you kind of have specific issues you run into. So from a supine position, they tend to breathe very poorly. Their abdominal girth tends to compress their diaphragm, so they're not able to take large breaths. You also have compression of the great vessels. Um, and then the other thing is, depending on the length of the surgical procedure, we've had multiple case reports of rhabdo in these patients if they're kind of left in that position too long. How long is too long? It can be as little as 3 to 4 hours, but it really sucks for these patients when they go through and they do fine with whatever the underlying case was, but they wind up with rhabdo and then ultimately renal failure and death. So what do we do to kind of prevent that? We're going to talk a little bit about positioning stuff, but the big thing is, moving them around, limiting the cases, kind of having a healthy respect for the surgeon as well as the case itself. So these people aren't in kind of a weird position for too long. There are also a whole lot of positioning aids out there that are a little bit kinder and gentler. They're almost like a foam microfiber that works pretty well. So it helps kind of distribute that. When we turn these patients prone, and we're going to look at pictures of all these positions in just a second and kind of talk about the individual complications, you're distributing a whole lot of body habitus on very small pads. So as a result of that, they may have excessive pressure on those pads. As a result, underneath that, you tend to have skin breakdown, which, just like above, can lead to tissue necrosis, rhabdo, infections, and death. Turning these patients lateral, you tend to wind up with kind of downward issues. Hip ulcers tend to be one of the biggest ones because that's kind of like the teeter-totter positioning there for these patients. Uh, the other thing is things that you commonly do may not be beneficial at all. So, for instance, putting an axillary roll on somebody with a large body habitus may be meaningless because they just absorb it. So just kind of look at the patient and think about things like that. If it's something that's really necessary, you may need to exaggerate it or kind of alter its positioning to accommodate for things. If we have a choice, there's lots of times we can do cases in multiple different positions. So as opposed to turning somebody prone, we may put them in like a lateral decubitus or even like a sloppy lateral position. And that to help us out a little bit with the pulmonary issues. And then lithotomy issues we run into. Um, the stirrups may literally not support the weight. So just think about your positioning aids. Make sure you're aware of the tolerances, not only for the different kind of OR tables, but also the accessories with them. They do make kind of extenders, not only for the bed being wider, but also longer. So that may be beneficial for those patients as well. So we'll look real quick, see if you guys have any questions, and then we'll move on to talking about the actual positioning.
In addition to the extenders, do
Go
they
ahead.
also have like bariatric OR beds or no?
They do. So what you'll see is a lot of times the bed itself will take the weight if you get the right table, and it's positioned the right way. Lots of ORs will have like a list of literally like this bed, this is how much weight capacity it can take. But it also depends because they usually have kind of that platform underneath. So it may be able to take, 800 pounds when it's centered, but sometimes the bed's been slid one way or the other, and that may alter things. So be very cautious with that. But they do make bariatric beds. The problem you run into, depending on the case, if the bed gets too big, it's almost impossible for the surgeon to get to the patient. So I haven't participated in it, but I've heard of surgeries being done on the floor. You wind up doing some sketchy things. I've seen two OR tables pushed together. I've seen patients having surgery on stretchers because the OR table wouldn't accommodate them. But like I said, usually the problem is not the table itself and what it'll support. It's the surgeon being able to access the patient. And I've got some pictures we'll look at in just a minute that kind of go through some of those things. Marley said, even if you had the patient hold it for 2 weeks, would you still RSI them? Going back to GLP-1s. Personally, if I'm ever in doubt at all, I just RSI. It's not a big deal to me. I make sure my patient's got enough medications they're not going to have awareness, and then I just move quickly to put the tube in there. Other things, and I started doing this during COVID and never really went back. I don't ventilate my patients during induction unless I have to. So with that being said, like I'll push my probe, push my rock, and then tube. I don't push the probe, then ventilate, and then push the rock. If you actually look at the research, it shows that the whole thought process there was that if you couldn't ventilate them, you could wake them up. The problem is the propofol won't wear off before they're dead. So you're better off getting to the best intubating conditions possible faster. So if I'm ever in doubt, I RSI anybody. It's not a big deal to me. Like I said, I think the big thing is just to make sure that your patient's adequately sedated.
So you do, so now your new process is you just do them both simultaneously, just hit them hard and fast.
Yeah, what I'll do is and they're gonna get other stuff. Even if it's somebody I'm not giving Versed to, I'm gonna give them. If I don't give Versed, I'll give ketamine or I'll give Precedex or something else. So there's multiple agents in there to help with sedation and amnesia. And then I'll just give my propofol and then chase it with. Now, I may not give the full RSI dose of rock. I may just, give 50, 60, something like that. But I don't ventilate afterwards unless I have to. But the important part of that is making sure you do a good job of pre-oxygenating your patient.
I see. Okay. And then what's your threshold when it comes to awake intubation on these folks?
It really depends on the patient. Going to sleep isn't the problem so often as waking up. Because going to sleep tends to be a very fast process. Even if I'm doing a glide scope or a fiber optic, that tube's going to go in pretty quickly. Where you'll get into trouble is not pre-oxygenating them and not waking them up adequately. So whether you overly sedated them or they were in bad position, that's where you tend to get into trouble with these folks. It can happen going to sleep, but even if I have to do a fiber optic intubation on them, it's going to go in pretty quickly. All right, so we're going to look at some different positioning examples. So this guy's turned lateral. So what issues do you guys see looking at things right now? So we'll start down at his legs. So what are we using to secure him on the bed? And this guy, it really isn't that big, but you've got a Velcro strap. That's probably not the greatest. As far as padding over his hips, we've got a towel. Like I said, we improvise in a lot of these situations and it tends to get us in trouble. Sliding up to his chest and abdomen, I assume we're doing something in his, like a thoracotomy or a nephrectomy or something like that from the positioning. But it could be something different too. But a caution there is he's not very well supported. He's not very well padded. Looking at his down arm, it looks like it's probably sunk down into the bed. So I worry about nerve injury there. At least we do have some kind of pink foam on his arm up above, but I'm not sure how well that arm is secured either. So just be cautious. And like I said, this guy's not even that big, but this could easily be problematic for you. And they get a little bit more exaggerated as we go on. So things to think about. We put people in really weird positions for surgeries. So just be very cautious. This lady is secured to the table with Coban. I don't want my patient being secured to the table with Coban. You need to have solid straps. Velcro may work, but a lot of times what we're seeing is things with solid connections like either friction locks or buckles. Coban is not an answer. Obviously, they used it in this case, but not a good choice. The good news about having somebody in lithotomy is it does help secure them. But the bad news is look at her legs. Do you see how wonky she is on this table? It's a setup for so many issues, in addition, just her body habitus. So here I would worry about pressure on those calves. I would worry about back. Um, Even if it's not related to the surgery at all, just imagine laying like this for a couple hours as a young, healthy person. You're not going to walk well when you get up. Other things to think about when you're using this Coban, especially if you look like underneath this breast up here, she's going to wind up with a pressure injury there. I would worry greatly about that as well. But these are just kind of some examples of the things that you see happen. Most of the time, the facility has other resources. This is just us being lazy and not getting the appropriate stuff for these patients. And I say us as a surgical team, not necessarily us as anesthesia providers. So this is somebody prone on that Jackson frame, and this is what I'm talking about. You see how there's these pads that are kind of holding him up? One, they're not properly positioned. This pad should be a lot lower underneath his abdomen because I would worry about this guy sliding through the table at this point. But because the body habitus is distributed on those pads, they're at increased risk for pressure ulcers and breakdown there. Almost all the neuro cases you do are going to be on a table like this because it allows them to get in underneath the patient with the C-arm. So when we were talking about tables, I said most of them have that pedestal underneath. This one is supported at each end so they can get that C-arm in there. So that's a little bit different for you. The other thing is you don't have a solid kind of table platform here. So you really have to worry about what's going on with these pads and how well your patient's supported. This is somebody large on a similar frame. This is more of a fracture table-like frame. But the same issues that we're dealing with here. If you look down at the knees are very poorly supported. What is this holding his feet up? Can you guys see that?
Is that a chair?
I think it's
Is that a
actually
walker?
It's not a walker. It's like an OR table, but still not a good choice, right? Can you imagine if something bad happens and they found out this is how you position the patient for the surgery? So the other thing to think about, when you look at this table here, if you look on the left side, you see that that's where the pedestal or the base is. He's extended so far out away from that pedestal, that's going to be really unstable. I don't think that putting this OR table there was a good solution to try and balance out the surgical table, right? So, if you can imagine when you take that OR table out, how unstable he's going to be in that position. So I would definitely worry about him falling. But this gives you an idea of kind of how extreme things can be. With the C-arm in the background, I assume they were probably trying to do some sort of either ortho or neuro case, and maybe they didn't have a Jackson frame. The Jackson frame would have been a lot more stable, and they basically created one. But if anything bad happens, this patient falls, the manufacturer of that OR table is not going to support you at all. The good news is at least they use solid straps on this guy, so it's not Velcroed in place. You can see it's kind of firmly attached to the table. So that's a good sign, but just be very cautious with stuff like this. Other things to look at, if you look at his arms up here, so he's kind of in that Superman position, but you see how there's no padding underneath that elbow? That's something I would worry about because larger patients are already at increased risk of nerve injury. Imagine when you're doing something like this and you don't even bother to pad it. So any questions about positioning? I know those are just a couple different examples, but it's kind of like to think about the what ifs. Yeah, figures are wild, but I'm telling you, like you will find some of the most bizarre situations and you look at it and it's like you're the one voice of reason. You're like, this is not okay. And everybody else is like, no, it'll be okay. And it's really like that normalization of deviance that it's okay until it's not. We keep doing things and we get away with it until we don't. Something else I kind of wanted to highlight for you guys. Be very cautious in any patient, but also obese patients about what's underneath of them. So like this OR towel, I'm sure they use this as like a draw sheet to get him over there. But imagine him laying on that with that kind of rolled up wrinkle for like 3 or 4 hours. He's going to wind up with breakdown there. It could also be as simple as something like your EKG leads. If I've got somebody large like this that's going to be prone, what I'll usually do is just take my leads off the front and put them on the back because I don't want them laying on that cable. Same thing with your face and like the cuff on the ET tube, those sorts of things. Krista said, what do you do then? just chart that you told them something about positioning. So it really depends on the facility and kind of your role in things. So if this is like day one and you kind of have that not so like comfortable feeling, read the room, see what your CRNA is saying. This may be something that's okay. Some of these tools that you guys are going to run into look like torture devices. There's a table they use for ortho, especially for like femurs and hips, called the HANA table, and it looks like some sort of medieval torture device. They literally like strap the patient's upper body to a thing and put a post in between their legs, and then they use it to pull traction, but it looks really awkward and uncomfortable for them. So it may be normal. It may also be that everybody else in the room is thinking the same thing you are. They've just kind of gotten away with it and made it okay for so long. So what do you do? It's really, is this the hill to die on, or how significant is it? Is it something you're not comfortable with, or is this something that's going to be really detrimental to the patient? Um, Especially as a resident, you're kind of in a weird position. Usually I'm going to talk to the CRNA and express my concern, say, hey, I don't understand what's going on here. This doesn't look appropriate. Try and figure out what you can. Because it may be that everybody else is thinking the same things you are. They just haven't said anything or they've gotten used to it. Ashley asked about documenting positioning. So most of the time, you will document positioning at the start of the case and then at the end of the case. But there's certain things that you need to go back and reassess. So say like you have somebody you've turned prone. You want to go back that you looked at their face every 15 minutes and document that it was clear, there was an increased pressure or anything like that. And then as far as like kind of these weird positions, so the OR nurse is going to document stuff, but a lot of times you'll see that the details get left out. Like nobody's going to say I used tape to hold the patient to the table, even if they did. They're going to say they were strapped down or something like that. Um, so I don't know if that answers your question or not. All right, things that we see from an airway standpoint. A lot of times these patients have increased adipose tissue that kind of gets deposited in lots of weird places, but you'll be surprised how many really large patients aren't large on the inside. And like to put it bluntly, I'll say just because they're fat doesn't mean they're fat on the inside as well. Because they may have basically a normal body underneath all the extra body habitus. So it's a lot better to kind of think about the worst case scenario than go into it kind of lightheartedly. But you'll be surprised how many of these patients you really think are going to be difficult and then they aren't. But a lot of times what you will see is there's increased adipose tissue that gets deposited into a lot of the airway structures. The tongue tends to be one of the biggest problems for us because they get that large tongue and it's really hard for us to instrument the airway. That's the nice thing about using like a fiber optic scope or a video laryngoscope because you're not trying to directly see things. So it's a little bit easier to see using that video scope than trying to see it directly. Other things you see is a lot of times instead of kind of having a round oropharynx, that it almost gets stretched out into kind of a elliptical shape. Um, Part of that may be because of our positioning. Part of it may be because of our airway use. You'll see a lot of times when people use like the glide scope that they tend to get the scope itself too close to the vocal cords. And when they start lifting up on the airway, instead of it being nicely rounded, it tends to kind of stretch things out. When that happens, it may be hard to get your tube in there. So sometimes you just have to relax a little bit. So things to think about as far as predictors of difficult intubation. Like I said, BMI in itself may not be the only predictor, but it's definitely something to consider. But look at your physical assessment of these patients. How much mouth opening do they have? Looking at their dental structures, what do their teeth look like? Do they have teeth? Where are they? If you think about somebody that's kind of has like buck teeth, that may be difficult for you to instrument. If you have somebody that's got retrognathia or micrognathia, that can be very difficult as well. Other things to worry about, what sort of neck mobility do they have? Sometimes the problem we run into is that we're not able to displace the mandible because there is a lot of extra tissue there. So that may be your problem. So consider different positioning for them. Sometimes I'll get them on the OR table and have them position as I would to intubate and then see what things look like before we even go to sleep. Other things you can do to kind of help yourself out. And it really depends on what your facility has. On the left side there, you can see that she's obviously not doing real well in a supine position. You can imagine that she probably doesn't breathe real great like that at all. So, some places have like nice things, like on the right side, you've got this troop pillow. On the left side, you've got kind of the improvised version. Unfortunately, the improvised version winds up happening a lot of the time because it's more customizable for the patient. Even if you have that troop pillow, it may not be enough for the patient. So you'll see that things like sheets and blankets are commonly used as positioning devices for intubation. The problem you run into is, say this lady's having like an X-lap or belly surgery or pretty much anything. When I've had to position all that stuff underneath of her, I'm probably going to have to take it all out for the surgery. And then on the back end, I'm going to have to put something back underneath of her because if she couldn't breathe awake while she was laying supine, she's certainly not going to breathe well in a sedated state being supine. So commonly what we do on the back end is move them over to the OR table, or not to the OR table, to the hospital bed or the stretcher, and then wake them up there when you can do it in a seated position. Other things to think about that are a little bit easier for us. Don't forget that almost all these OR tables and stretchers, you can sit up the head of the bed. So that may be a little bit easier for you because then on the back end, you can just lay the head down. You don't have to try and get all that stuff out from underneath of them. But commonly, you'll still have to put stuff underneath their head to assist with positioning. So you guys have seen this before, but just the axes that we're trying to align here, and you can see how the big thing to take away from this is you don't need to just lift up their head. But in these patients, a lot of times because of that extra body habitus, you're also going to have to sit up their shoulders and then their head. And it may be a multi-step process. So commonly what I'll do is put a blanket underneath their shoulders and then 2 or 3 blankets underneath that head, and that puts them in a little bit better position for me. And then don't forget the role of kind of extending the neck. So this is where if you had somebody that had limited airway or limited neck mobility, it may be problematic for you. This was kind of a cool study that was very basic and pointed out what we already knew, that if you sit up the head of the bed, you can improve your intubation success pretty drastically. So like I said, you don't have to have these expensive positioning devices. You don't have to have all these sheets, blankets, and towels. You can just do something like this. The other thing, remember because they're pulmonary issues and positioning issues that they're going to desat very quickly. So especially when you're a resident, take advantage of that time to pre-oxygenate the patients. I can't say that to you enough. What I'll do with these patients is as soon as I roll into the room, I put a pulse ox on them if I didn't have one in pre-op so I can get a baseline sat. Because lots of times their pre-op saturation is not going to be normal. It may be only 93, 95, but it's going to be low. So that way you kind of know what you're working with to start off with. And as soon as I do that, I start oxygenating them. And that way, the whole time I'm getting the rest of my monitors on, the whole time I'm getting everything set up, they're hopefully doing a good job of pre-oxygenating. And these are the people you may consider using a mask strap or getting somebody to hold it on there for you or something like that. Because as you can see, they desaturate a lot faster than a normal body habitus would. On the back end, we kind of think about things that we can do to prevent atelectasis and desaturation. Um, so when I'm getting these people to pre-oxygenate early on, in addition to using that mask strap and making sure I've got a good seal on there, sometimes I'll close that APL just a little bit, maybe just 5, maybe up to 10, to put a little bit of extra pressure on there. And what that does is help prevent atelectasis, but it also kind of expands those lungs out. Sometimes they feel like they're breathing a little bit better. Sometimes they feel like they're being smothered. So you have to be very cautious with it when you're using it. But same thing on the backside. When I'm waking these folks up, I'll do the exact same technique. Other things to think about, like I was saying, head up position works a little bit better. So get them up like 25 or 30 degrees head up. And a lot of times it winds up even being more than that. But you have to be cautious because if you sit these patients up too much or in kind of a weird position, especially if you're just putting the head up, then you almost like fold them up on their belly and it may make it harder for them to breathe. So with that in mind, sometimes we'll just put them in like 25 to 30 degrees of reverse Trendelenburg, and that way their abdominal girth goes with them. But be cautious when you're doing this to make sure that they're strapped and secured to the table because as you're standing them up more and more and more, they do tend to slide away from you. Other things to think about, getting them on the ventilator quickly after induction. The ventilator is going to do a much better job of oxygenating and preventing atelectasis than you will. So we want to try and avoid hand ventilating these patients if we can. So if you can get them on the vent quickly, it works out pretty well. Other things to think about during the course of the case, what you do to kind of maintain the recruitment you've achieved. So think about it this way. If you spend the whole case doing a great job ventilating them, and then to wake them up, you turn off the vent and hope they magically start breathing, you just gave up any sort of recruitment you'd accomplished. So consider waking them up on CPAP or PSV Pro or something like that. So you're able to keep a little bit of PEEP on there. They tend to do a little bit better with that. Other things to think about, and we touched on this earlier, as far as different airway techniques, you obviously have to worry about aspiration in these patients. So, things you can do to reduce gastric volume and increase pH. I usually use at least one prophylactic agent for these patients, but, obviously if they get larger or I'm starting to see that they have pretty significant GERD, anything like that, I'm probably going to start adding to it. And then, like I said, if you're ever in doubt, go ahead and secure that airway quickly. Whether it's because you don't think you'll be able to ventilate them or you don't think that you'll be able to intubate them very easily, I would probably quickly move through my airway stuff. Now, it's a very fine line between doing an RSI and doing an awake fiber optic. Part of it just comes with time and experience to know whether this is somebody you think you'll be able to get the airway secure quickly. Other things to think about, we don't necessarily have to do general anesthesia on all these people. As I said, regional or neuraxial may be our best choice, but those come with their own challenges as well. If you think about things like spinal epidural patients, they can be very difficult for obese patients. You have to think about, do I have the right equipment? Longer needles are kind of a big deal. Some places have lots of long needles, some places don't. So figure out if that's something you can safely do, what equipment you have. Other things to think about, an ultrasound's kind of a game changer here. Like if you look at that patient on the left side, identifying spinous processes may be very difficult to do. The ultrasound may be really kind of your best friend there as you try and find things. But like when we were talking about airway stuff, just because people are large doesn't mean they necessarily have a large back. So you'll see that a lot of times people will have like abdominal obesity, but you may be able to find spinous processes very easily. Other things to consider, you may see not necessarily going to a lower dose, but anticipating that you're going to need a lower dose. Their epidural space tends to be a little bit compressed. So as a result of that, you may use lower doses for those patients. There's obviously also an increased rate of block failure, probably due to technique and patient positioning, but it's something you have to account for. And then the other thing you see, even in non-pregnant patients, is that they tend to have a higher rate of hypotension after an neuraxial block because of compression of the great vessels. So you may want to consider doing some co-loading of fluid for those patients to prevent that. As far as monitoring goes, be cautious with the blood pressure cuffs. A lot of times what we do is if the cuff's too small, instead of getting the appropriate size cuff, we move it down to their forearm or put it someplace else. Most of those cuffs have marking on them. Make sure that the bladder is going around at least 3/4 of the arm. If not, you probably need to either find a correct size blood pressure cuff or use an arterial line. You should probably have the correct size blood pressure cuff either way. There are other issues we run into that we've talked about a lot as far as like invasive monitoring, and then all the comorbidities that are associated with these patients. So just be cautious. As far as what technique works best for them, again, be very cautious. There's not really a perfect plan for these patients. It really depends on the surgery, the patient, and what's going on. Um, I would be a little wary of anything that causes excessive sedation. So sometimes we'll go a little bit lower on the opioids. We may use lower amounts of sedatives for the patients. You may consider like foregoing something like a benzodiazepine that may cause respiratory depression. Usually we try and go with shorter acting agents. So think about things like remifentanil especially, although you're still going to have to use something for a little bit longer pain control. Things in small doses may be okay, like dexmedetomidine, but you have to be very cautious. If you go with kind of high doses of dexmedetomidine, it'll cause sedation for you as well. And then problems we run into as a result of our sedatives, you tend to have like a relaxing muscle tone, so just be very cautious that they're able to support their airway. As far as our volatile agents go, a lot of times it's preferred over something like propofol just because you have control over the situation. So if you're using propofol and you turn it off, depending on what doses you've been on for these patients, you may see that it's 30 to 60 minutes before you wind up breathing and kind of having a return of normal function. They will hold on to the volatile agents longer than a normal patient would, but you can get rid of them faster. There are also agents out there like desflurane that are kind of targeted for these patients, but you'll see that long periods of time, like over 3 or 4 hours, it really doesn't matter that they don't go away quite as fast as they would.
Okay to use the nitrogen for at the emergence phase, or just not at all?
So the literature says it's really not at all. Personally, I prefer it over a volatile because I can get rid of it. But the book answer is that you should avoid nitrous because they'd prefer you have oxygen. But like I said, what I'll usually do is if I'm going to use something, I'll consider running them on nitrous, and then I can get that out of their system a little bit faster than I can a volatile agent. But it really depends on the patient, the setting, because there are a decent number of contraindications for nitrous as well.
Well, I was talking about like for emergence when you turn on the nitrous to help wash out the volatiles because of that diffusion property of nitrogen.
Yeah, and in that case, I probably wouldn't. I would just continue with just 100% oxygen and give them a little bit longer to wake up. Does that make sense?
Yeah, sorry, having trouble getting that
Okay.
mic.
Yeah, no worries. And then as far as dosing, these are kind of recommendations, but we see that there's quite a bit of variability as far as what you should dose based on ideal body weight and what you should dose based on total body weight. I think the most common in clinical practice is that everybody's based off a total body weight for a starting point, but that they wind up decreasing their dose after that. The problem we see is that ideal body weight oftentimes underdoses even like lean mass patients. So just something to keep in mind. And you're going to see that a lot of these are really just starting points. You wind up having to tailor your dosage depending on kind of their response to things. We talked about this when we were looking at the positioning stuff. Just be cautious with these patients. The other thing is because they tend to have a lot larger surface area, they tend to get cold quicker. So think about what you can do to keep them warm and kind of keep them that way. So, if it starts with warming them in pre-op, getting them warm then, and then keeping it that way throughout their time in the operating room, it may be a little bit easier for you as opposed to getting them back there, letting them lay there cold for a while, and then trying to get a bear hugger and make up for stuff. Other things we kind of talked about this earlier. They do make, like I said, kind of extensions or extra arm boards. You may also see that you have to use 2 arm boards to hold an arm. Mayo stands are probably not a good choice, like I said before. This clear plastic thing down here is called a sled. You see this used a lot of times in like interventional radiology or the cath lab. Obese patients tend not to do very well with these for 2 reasons. One, they tend to not fit, so they're putting pressure on their body tissue. The other thing is they're not going to keep that patient's arm from falling off. They're just dependent on kind of friction and the body weight of the patient to hold it in place. So that big arm may push it off pretty easily. We talked a little bit about fluid stuff earlier, but anticipate having to give a little bit more fluid to these patients than you would normally just because of the increased risk of pressure injury. A lot of times these patients are a good choice for some of the non-invasive cardiac monitoring stuff, or kind of the using something either like the Acumen or the Cheetah or something like that. It tends to be pretty beneficial for them. On the backside, what do we do with these folks? So I think the biggest thing is kind of a basic thing. Sit these patients up, get them over to the stretcher, get them over to the hospital bed, and sit them up before you reverse them. These patients are pretty clear indications for Sogamidex. Even places that have kind of restrictions on Sogamidex will allow it in this setting. Now, it may depend on the patient's body habitus, but usually if it's a BMI over 40 or 50, it's pretty good to go. Other things to think about, like I was saying, consider putting these patients on pressure support or some sort of CPAP setting as they're emerging, so that way you keep them on a little bit of recruitment. Other things to do, I will usually put nasal airways in these patients prophylactically before I wake them up. So what I'll do is, kind of bathe those in lidocaine jelly. And then while they're asleep, I'll put them in there. That way it's not stimulating as they wake up. Because I may need them to keep that in there longer than an oral airway would be rated. So, and commonly I'll put 2 nasal airways in there, and they do pretty well with that. And then the lidocaine jelly makes it a lot less stimulating for them. We talked a little bit about a kind of pain management approaches. Usually I try and avoid things that won't cause excessive sedation and certainly things that won't affect my pulmonary status. So consider giving them a long-acting agent up front. So maybe like tramadol or oxycodone or something like that may be beneficial. And then as far as in the operating room, a lot of times I'll give these patients ketamine, dexmedetomidine. If you don't have ketamine or dexmedetomidine available to you, clonidine may work. Other things to think about for these patients, where you do this case. This may be a case that's normally done in like endoscopy, but because of the patient's body habitus, we may decide we need to do it in the OR. You'll see that a lot of offsite locations can be problematic for these types of cases. So you may want to bring them to kind of your anesthesia happy place and do it in the OR. And there's some references for you. What questions do you guys have?
So I'm guessing we